Hey y'all, happy Baby Friday. I am pleased to be joined today by my good friend and colleague, Miss Christine Hall. Hey,
Hey
Christine.
Betty, how are you?
I'm cold. I'm cold.
Oh!
I know. I was talking to our friends at BC Advantage, right?
Uh-huh.
Nicole Anderson. She and I email each other all the time, and she just emailed me, and she said that they just moved from where they were to North Carolina, and so in their cabin up there, she said they had smoke coming in from where they tried to start a fire in the
Oh my.
fireplace. So I think like the flue or something, you know what I mean, wasn't open.
Right. Sometimes
So
the birds
they
will
built
make
the
nests in
smoke
there, or the
and she
little
said,
animals will make nests.
yes, she said that they their heat wasn't working right yet. So it was like 45 degrees in her office and in the bedroom. And I emailed her back and I was like, well, I feel really like a wuss now complaining that it's like 50 and I'm freezing.
No, I told you last night we turned on the heater because I'm a little further south than you,
Yeah,
but that doesn't mean anything. That's heater weather. Anything below 70 is heater weather.
it certainly is.
And I know that I have my friends out there laughing right now from up north, but
But I mean, we have thin blood.
that's
That's
right.
how it goes. And I was telling you right before, in honor of Christine being with us today, because she likes to do her national days. Today is National Winnie the Pooh Day, so I thought that was kind of cool. And
Very
I
cool.
looked, and it's also Cary Grant's birthday and Kevin Costner's birthday.
Oh, Kevin Costner. I know,
Ooh,
right?
I can't wait for the new Yellowstones to start coming out. Oh, that's he's kind of quite a little cutie.
Yeah, he's aged nicely.
He has. Sometimes I'm like, as they get older, they actually are looking better to me. Like Sean Connery.
I was about to say, somebody asked me, like, who's on your list, Christine? And I was like, Sean
Mhm.
Connery.
Oh
That
yeah,
voice.
was always. Yep,
Mm,
yep, yep. Now Kevin Costner can kind of join him too. So, but yeah, let's see who
absolutely.
we got on here. Oh, we have Natasha here with us
Hey,
today. Hey,
Natasha.
Natasha. And Annette Bush. Hi,
Hey,
Annette.
Annette.
Jeanette.
Hey,
Hey, Jeanette. How are
Jeanette.
you doing? And I think because it has LinkedIn user on it, I think that that's Sonal, but I'm not sure because she shows as LinkedIn user on mine. You know how that comes up like you
That
did
happens to
on
me.
yeah.
Yeah.
And, oh, Haley, thank you. Two of my favorite people. That's so nice.
Hi.
Oh, Natasha's been in Florida too, and she says she's had her heater on for a month.
She's in Jacksonville. So technically, like she's a little further north.
Ah, okay.
Barbara
Well,
Shaw's
so
here.
maybe
Hey,
we'll give it to
Barbara.
her.
Oh, look at Lady and John have joined us too. This is
Oh, hey,
great.
lady. I had to. Ah, my good friend Sally. She's in Iowa, so they have real cold. So, hey,
Ooh.
Sal. So I'm glad that we have so many people on today because we're going to have a nice discussion about incident two.
Incident what?
That's a good question, right? I mean, I keep reading and finding stuff about incident two. It's kind of like when I had you on last time, we talked about modifier 25. There's certain things that you're like, this is just never going to die. It's not going to go away. And incident two is one of them. I truly, it's one of those things where you're just like, is it worth it? Is it, I mean, for practices, you really have to think it out anymore. It used to be like it was an absolute, everybody did it. There was no question about it because in the old days, you used to also be able to do it with commercial payors too. So now those are, getting smaller and smaller and smaller. And so, people are really having to decide if it's worth it. So
Well,
I
I
wanted to
remind
kind
people
of
that
discuss incident two.
incident two is incidental to. Think about that. Change the way you think about the word incident two, because incident two really has no meaning. It's what you're
Mhm.
trying to say. It's a billing benefit, right? But what you really need to be asking is it incidental to?
Mhm.
So what is it incidental to? That's a great
Mhm.
place to start.
Which is why I tagged this as incidentally speaking. Wasn't that cute of me?
That was really cute. I love a play on words. Anything that will stick in our mind and leave an impression.
Right,
Now,
right.
Betty, the thing that gets me is that if we think about incident two, and yes, we may have had rules in the past, but we've got to remember that the only constant in this industry is change. And incident two is a Medicare benefit.
Yeah,
You're not going to find those terms in any other payer's contract unless they're referencing Medicare's incident two, right? That doesn't exist. So we got to think about who are we talking about when we say we want to use this benefit.
right. And that's the thing with the benefit is that in our practices today, because the payments are getting worse and worse and worse, the conversion factor and all of that
Yeah,
mess,
I told you I
practices
was
really are looking, they're like, they have to make the money up somehow. They want to
right.
keep their doors open. They want to keep servicing patients. They want to keep offering services. Well, you can't do that. There was just a report on today of some hospital that had to, shut down because they can't financially be viable. I mean, a hospital,
Right.
that is a whole big line of service for many people in many communities. So when you look at that from a practice standpoint, a lot of practices are looking for ways that they can better use their APPs or NPPs, as Medicare calls them,
Well,
in.
we were at the 15th annual NAMUS conference, which was
Mhm.
phenomenal. And
Yes.
one of the things that Shannon shared with us was a reimbursement analysis of E&M services. And I want to make a note that we see incident two utilized most often with evaluation and management.
Right.
And so I get that we are losing money as time goes on. Over the last few years, we have lost a full-time employee in reimbursement equivalents, right?
Yep.
Um, so it is important that we understand these benefits because money's money, right? If
Yep.
there's a way that we can be reimbursed, um, capture that additional reimbursement when the NPPs or the QHPs or the APPs or the mid-levels, extenders, whatever your reference to those nurse practitioners, physician assistants, clinical nurse specialists, midwives, whatever your term is that you use for them. I get it, but we got to do it right.
Yep. Yep. And that's really where, having discussions and having sessions and talking about it can hopefully help people into kind of working their way through it if they're going to do it, because I hear a lot of people that say, well, just don't do it. It's just not worth it. It's not worth the hassle. But
But it can
15%
be.
difference in payment, 15% is 15%. And if you
Yeah,
look at how many patients an APP might be seeing in the practice and how many you have, that's a lot of money to just say, oh, just don't do it. It's not worth the hassle,
I
you know?
agree. But I think we need to put together at very least a policy with procedures, if this then this, and that it needs to be methodical, and everyone in the organization needs that training, not just the docs, not just the
Yes.
medical assistant, not just the biller or check in or check out. Bring everybody together and say, look, you know, um, this is what potentially this could bring to us if we do it correctly.
Yeah.
And so get everybody on board. I think that's where you're going to see the biggest benefit, is when it can be done successfully, and you've got multiple people there to make sure that that process works.
Yes. Yeah, I think that would be an excellent in-service to have for a practice that, and most practices these days have APPs in them. I mean, it's just kind of like the thing now. So I think that would be a great in-service for an entire practice to have kind of okay, we're going to have a lunch thing, and maybe even for 2 hours, close everything down. We're going to have somebody come in and, go through all the stuff, put it in their compliance program, make a policy, like you were saying, of all of these things and how we're following it. And then, start to push it out.
I like having
Because
something to fall back on. I like
yeah,
that policy. I like that, listen, I'm a lady of a particular age, Betty. I don't
I
remember
know.
everything. It's always nice to be able to say, ooh, I do remember that there was a policy that came out and we had that education. Let me go grab that and reference it.
Yep.
This makes
Yep.
sense to me.
Yep. So yes. So the first thing out would be, what is incident to, for people that are watching and listening that maybe haven't used it before. So we're been kind of like 10 minutes now, and we're throwing it out there, and that made me think, oh, there could be some newer people, new into the industry, things like that. They're just like, what are they even talking about, right?
Yeah, my
So
doc says that we just bill everything under the doc.
yeah, don't you?
That's the way we do it. That's what I was told. That's the way we've always done it. Those nice little
Oh,
catchphrases.
yeah, that's one of the most cringeworthy, right? Oh.
Oh,
Now, for those of y'all that want to do a little investigation on it, CMS does have a whole bunch, of course, because it's a Medicare benefit. CMS has a lot of information. They have a whole page devoted and bunch of links for incident to specifically. So if you want to check it out, here is the link where you can go to and then, delve more into it besides the time we have today, because as again, it's a little specific thing, and most people think, well, it can't be that hard. And then you start adding the but what ifs in there.
yeah.
And then it gets a little trickier. So, go check out the site on CMS's website there, and go through all their material. There's a lot of material there to kind of delve into it a little bit more and do some research, and then call people like Christine, like myself, if it's something that you're like, yeah, I think we can make a go of this, so that it can be done right and you don't end up paying back a lot of money. I had a practice that unfortunately called me because they had been just a regular records review from Blue Cross. They said, we just want to see some records. It was just their time, kind of thing. Send all the records off. It was a physician with 3 PAs. And then Blue Cross came back and said, well, we noticed on your records review that the person that was on the 1500 wasn't the same person that did the service for the day. And, and their response was, well, no, we billed it incident to. And Blue Cross's response was, well, we don't accept things that way. If you go look at the policies on the site and under your provider agreement, it says that if they can get their own NPI number, they must bill under their own number. So they didn't accept incident to. And so they had to do quite a large payback. So that's not where you want to find yourself.
I had
you
one
want
a
to
couple
make
of years
sure
ago.
what you get, you keep, right?
A similar story. I had one a couple of years ago. Walked into a practice. We did a little audit, again, compliance audit, a baseline audit. We looked at 10 records for each one of the providers, and same thing happened. And I said, "Wait a minute. These were all billed under the physician, and these visits were performed by the nurse practitioner." "Oh yeah, we bill everything incident too." I said, "But this is a new patient, and this is a new problem, and this is how did no, that's how you do it." And I said, "Okay, I don't know everything. Show it to me." Oh, well, like you said, there's a lot of resources out there, and CMS keeps this is not a secret. There's no new changes. Incident 2 has been incident 2 since the inception of it. So I think it was in the 90s,
Yeah.
late 90s, when we got incident 2. And it is in the claims benefit manual and in the claims processing manuals of Medicare. There are a lot of resources there, just like Sonal said. Novitas has a wonderful resource. Any of your Macs are going to have great resources on this. Annette's asked about clinical pharmacists. So I'm not 100% sure on the clinical pharmacist, because there may be not an LCD, but an article. Sometimes CMS will also put out articles on certain topics for nuances like clinical pharmacists. And that's where my mind goes. I would look for, in the MCD database, I would look for an article, a local coverage article that might cover that, Annette, just to give you a go-to.
Yeah. Well, incident 2, again, we started to explain it and then we got off on a tangent again. But incident 2.
That's what happens when friends get together, Betty.
Incident 2 is a Medicare benefit to where they call them NPPs, so non-physician practitioners, can work under a physician and see a patient incidental to that physician and bill for it under the physician's NPI number. So what that means is that they get paid full fee schedule, so 100% for the visit that the NPP did. Whereas if they had billed under the NPP's number, they would get that 15% pay cut because they're not a physician, right? So, I mean, that's where the money comes in and where you're saying, wow, that 15% patient after patient after can add up. Now, you don't have to do everything as incident 2, as you were stating before too. Now, you can have an NPP that sees some patients incident 2, some patients on their own. They can go back and forth. There's not anything wrong with that, or any kind of trouble you can get in. Your documentation just must support the fact that it's an incident 2 service. Okay. So now the guidelines. I made a couple on the main ones that hit me when I think of incident 2, of the couple main kind of rules you have to keep in mind. So the first one is that the supervising physician, there's a lot of people that get in trouble for this one, has to be in the office suite, immediately available to provide assistance or direction if needed. So
well, this reminds me of something, Betty.
Yes.
So we're not talking about a collaboration agreement between a physician and a non-physician practitioner. So depending on what state you're in, there's different types of collaboration agreements, or whether a collaboration agreement is even necessary in your particular state. Not all states require it. But in order to practice medicine, which has nothing to do with insurance and nothing to do with how you get paid. For instance, in the great state of Florida, if you are a nurse practitioner or a physician assistant, you have to have a collaborating agreement with a physician. It means that that physician will be there as a liaison for you. They will be there to talk about patient problems. That collaboration agreement could also include things like they want to review some of your records, or they want you to call on every 5th patient, or whatever that agreement looks like. Again, that is for licensure and to practice medicine. Has nothing to do with how you get paid for those services. So I want to remind people out there, a collaboration agreement is for licensure purposes, has nothing to do with payment. So put that out of your mind, right? And the supervising physician could be the physician who had seen the patient initially, or it could be a physician who happens to be in the office that day who is immediately available to assist the NP or the PA. Now, I want to remind you, NPs and PAs, they can practice medicine. What we're talking about is if you want to bill it under the doctor, that doctor's got to be there that day. Okay, that's what we're saying in this. If you want to bill it under the doctor, that doctor's got to be in the office.
Yes.
That's all we're saying. Not that that NP or PA needs supervision, but if you want to bill it, they got to be there.
Yeah. And then that is the thing that I get my practices when I work with them sometimes get messed up. They're like, oh, well, we billed it under Dr. Smith. And I'm like, well, who was in the office today? Well, Dr. Jones. I'm like, well, then why did you do it under Dr. Smith? Well, that's who they have their agreement with. That's not what this is talking about. You know, it's who's in the office today, what physician is
Right.
there to supervise. So you got to make sure you're doing it right, because I had a practice got in trouble because they were doing it under the collaborative agreement ones. And they got dinged because they said, you know, this physician was over at the hospital or this physician was out of town. How could they be supervising?
I do
So
want to
make
address
sure.
Julie's comment. Julie Leonard has a question. Until the
Okay.
end of 2024, I thought that direct supervision could be furnished immediately available audio video. Is that correct? Julie, yes, technically that is correct. However, I have a problem, and I think that this could come up of how can you be immediately available to assist when you're not there? That extension was allowed during COVID, and it was really intended for when we were on lockdown, right? And it was not safe for the provider to be in the office suite, maybe, or they were somewhere else and we still needed to have that direct supervision. So I'm going to tell you that technically, yes, that supervision can be audio video, but how seriously can they provide immediate assistance if they're not in the office? And so I think, just because we can doesn't mean that we always should, if that makes sense.
Yeah. Yeah, that's a great point too. Yeah, you know, there was one of those things that they relaxed for the COVID stuff that, you know, I'm like, okay, when everybody was locked down, period, that was necessary. But now
You
I
said the
think they're
word.
taking advantage of it and they're just kind of, you know,
Yeah.
like, oh, I don't want to come to the office
Is it
today. So, you
necessary?
know,
Is it necessary to use audio video? What is that necessity today? And it could be, oh, I know, Julie, I know you're feeling me too. I see all your credentials, so I know that you speak the same language I do. But it's a good way to talk to providers and to remind them again that we're talking about necessity. And if the necessity is not there, then how are we supporting the integrity of that benefit? We're talking
right,
about billing,
right,
right?
right. So yeah, so that's our first thing, our first big thing. So for our second one, when we're looking at is this incident to or not, is that they have to be performed as part of the patient's normal course of treatment. So that's that other one. That's what makes it incident to, right? It's incident to something. So the supervising physician has to personally perform an initial service, lay down a treatment plan that the APP is following. That's what it's incident to. It's incident to the treatment plan the physician made. See, now is it clicking, everybody, right?
Right. It's
So, and they have to
incidental
remain
too.
actively involved. So that's the piece, another one of those gray pieces. What does actively involved mean, right? So with my clients, and you can tell me how you tell your clients, you know,
Mhm.
with my clients, they usually make in their policies, they'll make something in there to where it'll say the physician has to visit with the patient, have an appointment with the patient at least once every 6 months or at least yearly or you know once it, so that
Agreed.
shows their active involvement, that they're checking and saying yep, treatment plan is still good, we're on course, you're good to go, and then the APP takes back over again to do the incident
You
visits.
know, a safe policy to have would also be, and this is just a suggestion,
Mhm.
is that the physician needs to see the patient when the plan of care has
Yeah,
been changed by the NP or the PA, right? So again, if the plan of care changes, that's not going to be an incident to visit, right? We're going
right,
to build it under the NPP.
right,
But we may require that the physician now see the patient next, reestablish that plan of care so that we can continue incident two with that new plan of care that's been put in place. And it's not that the provider sees the patient for the very first visit and then never sees them again. We're
right,
talking about the establishing a diagnosis, a treatment plan that is followed. So we are incidental to that diagnosis and that treatment plan, right? And it's, again, if anything changes, if that NPP says, Betty, your blood pressure's off the chart, girl. I got to raise your medication and I need to send you to a cardiologist and I'm going to order an echo and a stress test. We're no longer following that established plan of care, and it's no longer incidental to a previous visit. We're making a new plan of care. And that NPP, I love my NPP. Don't get me wrong. They have the authority to do that. But we just bill it. Remember, we're talking about billing. We're bill it under that NPP, give them the credit for that visit where we had an exacerbated condition that needed to be treated. And I'm going to pop one more thing off here. Woo! That means that if Betty goes to see her NPP and the NPP has to change that plan of care, the NPP must be able to bill that visit. So it's not that she's not credentialed with Medicare. And so we have our NPP see Betty, but then the visit goes south. Betty and that blood pressure. And the doc's got to come in now and take over. Then we've wasted the NPP's time, right? Yep. And also Betty's going to be like, why did you have somebody that's not allowed to see me come in here anyway? Like, ooh. Exactly. So think about that too. Are they licensed and credentialed with the Medicare program so that when the visit is not meeting the requirements of incident 2, we bill it under the NPP? It's fine.
Yeah, exactly. And then our third thing that's common for incident 2, which again, when I looked at this, I was like, when I look at the rules for incident 2, I'm going through this, it was like, okay, the services must be of a type commonly rendered in the office or clinic. So this goes back to kind of like the split shared in the incident 2 thing, right? So split shared is for inpatient, is for, right? We never do split shared in the office. You can call it whatever you want, but those rules don't apply in the office. So incident 2 applies in the office. You don't do incident 2 in the hospital. So, you kind of,
right.
Take a look at that. And, you can't have brain surgery being done, by a PA saying it's incident 2, because you wouldn't be doing something like that. And at least I hope you wouldn't be doing something like that in your office.
Well, also they're saying that, the things that you would do incident 2 might be, you could have a plan of care in place that the patient has pernicious anemia. And I recommend that the patient have an injection of B12 once a month. So they come in and they see the nurse practitioner who says, yeah, I just reviewed your labs and your pernicious anemia is a little, it's still there. And we're going to continue this plan of care and give you B12 shot. And she might do that B12 shot. The administration of the injection is a service that commonly happens in the office. And so that could also be billed incident 2, that administration of the B12 injection. So those types of things can be done incident 2. I do want to caution x-rays, imaging, things of that nature that may have a state supervision requirement rather than a payer supervision requirement. So cautious on imaging in the office as an incident 2. Imaging also has its own benefits. So I would ask more questions about, but given a shot, brain surgery, no.
Well, and if I was the patient, it would be some other word in front of that no. It would be a little more
Although forceful. I got to be honest, did you ever have one of those COVID tests where it felt like they were going to your brain? No. Yeah, that's what I'm talking about. Oh, no, not it. No.
All right, so let's take a look here. We've got like a whole bunch of activity going on over here. Ooh. So, let's see, Caitlin, do any payers have a published frequency for how often they should see the patient? The health system I worked for schedule it every other visit. Now, again, Caitlin, that's a great question. Like I said, Medicare on the actual guidelines, they just say actively involved. They don't tell you what that is. And I don't know personally of payor that does have a frequency that does accept incident 2. So I think it's more of an internal policy of what you feel would meet medical necessity for the patient and what feels right to, your practice is what
Right.
I would say. But I don't know. Christine, do you know
Now,
of any payor that
no,
has an
they
actual
leave that
listed
to the
time?
provider. So again, like Caitlin was saying, it's not a bad idea to have an internal policy to define that. And in her organization, it was every other visit. In my organization, it was with a change to the plan of care. In your organization, it was at least annually or every 6 months. So, again, the beautiful thing of having a compliance program is that you have the opportunity to speak with those specific keynote people or key people in the office, clinical people, administrative people, to see what works best for your organization. Here's the policy. They must stay actively involved. What does that mean to our organization? And to put that in place. Great suggestion.
Yeah, to me, I always think about it as defense. So if a payor is looking at your stuff, Medicare comes to look at your stuff, and they see that one physician in the practice saw the patients as new patients and never saw them again. Was signing off and everything, but then you've got another physician that you can see is like every couple of months is seeing the patient, or like you had mentioned, when there's a change of a treatment plan, then they see them the next time, and you can see that that's actively involved. So you need to be able to defend whatever action you're taking to where it makes sense to somebody, especially an auditor on the other side that's looking to try to take that 15% away from you. So, I mean, it has to be something like, well, no, and here's our policy. Here's a copy of the policy,
Yeah, but Betty, think about this too. We expect that people will get better or become stable. And if you become stable, then do they maybe decrease the medication to see if they can do that? You're not going to see somebody for 5 years and everything be the same all the time. If you're dealing with a condition that was previously diagnosed. So now we're not talking about those one-offs like an upper respiratory or
right.
allergies, or we're talking about chronic conditions. Let's just use hypertension per se. If I have hypertension, my doctor says, Christine, your goal is that your blood pressure will be below 130/90. We're going to put you on, metoprolol, and you're going to come back and be seen every 3 months or every 6 months. At some point, I'm either getting better where we might decrease that medication. Maybe I lost weight. Maybe I started going to the gym. Maybe I'm eating better, and you would decrease that medication. I would not expect that 5 years later, I'm still sitting in the same boat. And so there needs to be that physician involvement who can say, nope, we years gone by, her blood pressure is great. We're going to keep her on that medication. Are they checking my liver? Are they checking my kidneys? What are you doing? You're not going to just leave me out here so normally, I think that providers should get involved if they're going to change that. Again, we're just talking about for payment purposes, folks.
Right.
We're not saying that the nurse practitioner can't do all of those things, because they sure can.
Yeah.
But then they bill it under their NPI.
Right. And then I see here's a hot one. Sonal. It was asking, I think it's Sonal, because again it says LinkedIn user, that is asking about another MD doing supervision to another MD, and I know that is a hot topic question that we get lots of varying opinions on. So I'll give my opinion. I'll ask you for yours, and we can see what other people have to think about this one, because I think this is a great question. So and if it's you, Sonal, hey Sonal, so can another MD provide supervision under incident to, or just the main MD? Oh, I'm sorry, I misunderstood her question.
No, but I was hoping you were going where you were going. I was
Okay.
hoping where you were. We did answer this one earlier.
Yes,
we
we
answered
did.
it as whoever's in the office is providing the supervision. That's what we built. But I'd like for you to finish your thought, because I get that question a lot.
So if you have a physician that's, say, a new physician who is not credentialed yet with Medicare, can that physician see patients incident to another physician in the practice? So that's the question that I get a lot is, can incident to be for anybody that's qualified to see patients? Can you use it for anything? And from my research, technically, I think the answer is yes. You can be incident to one physician can be incident to another physician, but I think it brings a whole lot of, well, if they're not credentialed though, they have to be able to bill Medicare on their own. If they are a credentialed physician, and for some reason, I don't know why they wouldn't want to bill under their own, because that kind of brings it, well, are you under the LEIE list? I mean, what's going on? Are you not supposed to be doing business at all? But technically, an MD can be incident to another MD.
Well,
So,
I look at it a little bit different because
mhm,
the incident to benefit is a billing benefit. And the
mhm,
benefit is to capture that 15%. So that tells me that it is, and it is laid out as non-physician practitioners. It is laid out as ancillary staff. Does it exclude physicians? No, but it also doesn't include physicians.
mhm.
And it does include those NPPs and ancillaries under incident two. So I have heard that it has been argued in court under after an attorney has been hired and you've got a consultant on board. I have heard that it has been used as a defense that because it doesn't say physician, we cannot automatically assume that we cannot do it of a physician. But it is my interpretation, without having to pay for a lawyer and go to court, by the way, it is my interpretation that because it does have a distinction for non-physician practitioners and ancillaries, and it's a payment benefit, I don't advise my providers to do that with physicians because, again, it doesn't fit into the intention of the benefit. So,
Oh yeah, I never advise my clients to try it, but I know it's
have
come
I
up
heard it
many
before? I've heard it
times.
before. Surely. It comes up a lot. Well, can I get away with doing that?
Uh-huh. And then we have let's see, Amelia. Is it Amelia? Amelia
Yeah, Amelia had a
Weber.
great question.
Yeah, she's got a great question there. Is by where Caitlin Brack's question was that you had put up, Mary.
Yeah, it said, oh,
Yeah.
I did that? I didn't know I could do that. Look at that.
Oh, it's
She
my
says,
understanding that if you're billing incident to and get audited, you must be able to provide the plan of care established by the MD to support the APP is following that plan of care. Is that correct? Well, if you are wanting to keep your 15% payment and you're going to need to show to the auditor that it truly is incidental. So the only way to show that it's truly incidental is by showing the original treatment plan that the physician who saw the patient laid out.
and
So if you get audited, that is something I would say to, be putting together with the stuff.
I was
Here's the
about to
treatment
say,
plan note, here's
mhm.
the APP's note. So you've got everything. There's no questions.
And that's a great question, Amelia. And I think that what I often do when I'm consulting with clients is I'll tell them, hey, maybe you want to add a one sentence to your note that says today's visit is incidental to June 3rd by Dr. Bob. That one sentence will help match everything together in the event of a payer audit. So today's visit, and then behind it, that June 2nd visit. And there's a blurb that we should use, that we could use in incident two. Is it mandatory? No. Can you find that written that you need to? No. Is it good advice? Absolutely. Right. And people pay good money for that advice. So take it, my friend. One sentence. Today's visit is incidental to the date and the plan created by Dr. Bob, right? Just make it easy. And then, when you send back your records for that audit, send that original visit where that plan of care was developed, and that will prove that this is incidental.
Yeah, you're kind of cutting the question off before you get it, right? So make sure, that when, and I say when because it's probably going to happen at some point that everybody's going to go through an audit, right? So when a
Mhm.
payor asks you for records, and if it's CMS and that that's going to come up when they look at that record, send them everything they need to look at that record when you send them originally. Don't wait for them to come back and tell you, hey, we didn't like this, or hey, now
Right.
we're denying that because you didn't say this, for you to then send somebody to have to go back again and look at that record to pull out the other, because now you're just delaying, you're getting, the anxiety just in the
Well,
office,
and the cost.
the
Every
cost
time
of
I have
looking
to
at it
touch
every
it,
time you touch it,
yep,
right?
it
So
depreciates.
get it at the get-go. That way they're like, oh, perfect, thank you, we love you, we're gonna leave you alone.
And
You
tell
don't need,
providers, one sentence is worth 15%.
yeah,
One
yes,
sentence.
yes.
Yeah.
And in today's EHR world, where we have templates for everything, that's a little statement that can be made as a template thing, to where when the APP is seeing somebody incident to, they just click it and it appears and they fill it in to be correct. And then that could save a lot of headache on the back end. Let's see what other kind of, the question from Jeanette right underneath that is another good one. Have you observed instances of billing for services where the physician is unaware that their name or NPI are being utilized as the rendering
That's a
provider?
bigger problem than
That,
I think. I
yeah,
think that's a big internal problem, Jeanette,
yeah.
that you got to go have a talk with somebody in house.
Because again, remember the whole purpose of incident to is it's incidental to them making the treatment plan. So if the physician is unaware that somebody's billing incident to them, that's kind of a problem. I mean that shouldn't happen. So yeah, that's something that we used to, or should be checked out. In let's see, didn't apply. Oh, lady has a good comment right underneath that one. Oh my gosh. I used to work for a provider who had NPP seeing new patients while he was at the hospital. So two things wrong with that is incident two. Not two things wrong, because NPPs are perfectly well enough to see new patients, right? I explained the rules to him, but he believed that those regulations didn't apply to him because he was a
Oh,
small group. I insisted
oh,
it wasn't correct, but he was reluctant to bill for the NPP. So yeah. Again, in the office suite, I had one practice, Christine, they were fighting with the auditors because the practice had, it was one floor, okay, and there was a divider. They had one door, they would come in, and then there was like a divider where patients could be called into one side of the practice or into this other side of the practice. And the physician was on the one side, the NPP was on the other side. And because there was a wall with a door, the auditors were arguing that that's not the same office suite. So, I mean, people, they can get really, really
yep.
picky on this kind of stuff.
I saw one
So,
that was a suite on the 3rd floor and a suite on the 4th floor, both owned by the same entity, that the providers were interchangeable within the two suites, but because the NP was on one level and the physician was on the other level, didn't meet incident to requirements. Now,
yeah,
remember, again, we have a little bit of a lenience till the end of the year with the audio video, but only if it's necessary.
yeah, yeah.
And being on one floor or another, I can easily see that a payer might say that's just laziness, and we don't make the exception for laziness, right? And
Right.
also, one other thing is we're simply talking about Medicare. We're not talking about any other arrangement that any other
Right.
insurance may allow. In the state of Florida, Betty, Medicaid allows incident to as long as the physician is in the building. Doesn't say office suite, it's in the building. So you have to know the individual payers' regulations, right?
And the supervision too with those payors, who they allow to supervise who, and goes down a different
Right.
rabbit hole.
Yep. Yep.
But yeah, lady, we've all been there where, we have practices where our clients think that the rules don't apply to them because they're small, or because they only see. I had one practice that had argued with me that because they were pediatric, blah, blah, blah. And I said, well, remember, CMS is Center for Medicare and Medicaid services. So a lot of those pediatric patients you see get Medicaid. So
Yeah.
yes, those rules are going to apply.
And Medicare is not a payer of age.
No,
We
no,
have my kids were able
and
to go to their
stage renal.
pediatrician until they were 21.
Yep.
And you could have someone who is 19, 20 years old on Medicare because they have a disability. So there's always an exception. There's always the if.
And then Amelia, right under that, has a question rounding back with us. And that's okay if you miss it. I'm not sure now. I mean, when Christina and I start going, I'm not sure what we said and what we didn't.
Well, no, we were saying that the NP, if they're going to do that visit incident to, that the NP could make a comment that today's visit is incidental to the visit they had with Dr. Bob on such and such date. Does Dr. Bob need to make a statement? No. Dr. Bob, he doesn't need to. He sees the patient, he puts the plan of care in place, and he tells the patient to return on a certain day. Whether that patient sees him or the nurse practitioner, really it's going to be the nurse practitioner that's going to say, today's visit qualifies for incident 2 because I'm not changing anything, or today's visit doesn't qualify as incident 2 because, she's also got an upper respiratory today as well.
Yeah, and I've got two things to that. One, with my clients, I usually say the whole actively involved thing. One way that you can show you're actively involved is by signing off on the note for that day. Is that required?
I agree.
No. But once again, if you are looking at it from that, I'm trying to put up a defense. And if I'm showing to the Medicare auditor that yes, our physician was actively involved, one way to show that is by them signing off on the record that day, because that shows that they read through it, and are agreeing with what's going on. But I think maybe, Amelia, your statement, you might be, because what I thought of when I looked at that question was the path guidelines, that maybe you were thinking of, how the resident can make their note, and then the attending could just say, I agree with blah, 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 that they'd have to do that to bill. So it's not like that with the incident 2. And did you have something else, Christine? I didn't mean to cut you off.
No. I was just same thing that you were saying.
Okay. And then Elba underneath that, we covered this, but just to be specific, incident 2 billing rules, do they apply to all commercial insurers? Most, Elba, no. Most commercial payors do not accept incident 2, or whatever they want to call it. They don't allow an NPP to bill under a physician, an MD, and without that, and not have that pay cut. Most of them now, if you look in there, in fact, I know very few that will allow incident 2, if that's what we're going to call it, for commercial side. Most of them, if you look in like either their provider manual or their agreements, sometimes it'll be in their contracts where it will state that if an APP, NPP, whatever they're going to call them, if they have their own provider number, they must bill under that provider number. Usually that's what I see in the information now that will tell you can't do incident 2 for them. So if you are in a practice and you have a lot of commercial patients and you're thinking of, like wondering the same question, you need to contact the payors or be going on their sites and looking at their information to see whether they allow it or not, because most don't.
Yeah, it's no different. your payers, your commercial payers, they don't pay you exactly the same monies or dollars that Medicare pays you for each service. Your commercial payers may not require an authorization that Medicare does, or vice versa, right? Your commercial payer might require an authorization for a CT scan where Medicare may not require that. You've got to remember that not all insurance companies are the same. We talk about Medicare because, they're a federal payer and they've got a lot of very strict guidelines of things they cover and things they don't. But commercial insurances are private insurances. They don't have to follow the same federal guidelines. Now, remember that states have their own laws for commercial insurances in HMO products. And there might be a state law that prohibits incident to billing or prohibits any other type of billing from a commercial or HMO insurance. So there's a lot more to these billing benefits than just what you may have heard on a webinar or podcast. You want to make sure you're looking at authoritative sources like federal registries, like state statutes.
Yes. And then Elba, excuse me, Elba follows up with another question under there, and unless I'm backwards, I think you've got it backwards, Elba, right, Christine? May I bill incident to with the NP or PA as the billing provider and the MD as the rendering. The NP or the PA should be the rendering with the MD being the bill to, right?
There's no benefit to doing that, to say that there is no NP or PA that will that the doctor would do incidental to. The doctor has that full autonomy. They don't need to be supervised for billing purposes. They're paid at 100%. Remember, incident to is a billing benefit. It is a payment benefit to capture that additional 15% when the visit is simply incidental to a previous visit. Betty has high blood pressure. I want her to take medication. Come back and see if that medication is working. Well, then the nurse practitioner sees Betty just for that high blood pressure. If anything else is happening today, her blood pressure is too high, she has an upper respiratory infection, she's got that weird mole she wants looked at, that visit is no longer incidental to the previous visit. It's a whole new beast of its own, right? And so it wouldn't even come into play. So doctors would never do a visit incidental to an NP or a PA because they've got that full autonomy and they get paid at 100%. We're not trying to capture anything that is just a pass through from the physician visit. Does that make sense?
Yeah. So, and this, I should have made this one of my numbered points there, but I've seen a couple people alluding to this, and Lady even mentioned it. So again, because it's incidental to the physician, to bill it as incident to the NP, PA, the APP, the QHP, whatever, they cannot see new patients or establish patients with new problems. So again, to bill it as incident to, not that they can't do it, but if you want to bill it and get the full payment, can't be a new patient, can't be an established patient with a new problem, because then it's not incidental to a treatment plan already given.
New.
You don't have a treatment plan if they've never been seen before. And like Christine was just given as an example, if I come in for my regular old hypertension and then oh, by the way, or you start coughing up a lung while you're sitting there, then you've gone down that different path. You veered off that treatment plan. So, and that's where incident to gets tricky, because then, okay, and I've seen it in notes where they say, well, so do I need to stop and go get the physician, like you were saying before, Christine, and have them come in? I'm like, seriously, you're going to do that? The physician's seeing patients on their own as it is, and the patient's going to sit there and wait while you go get the doctor to come back in and try to.
And the doctor has to start all over, by the way, Betty.
Yeah.
If anybody is thinking that in their office, when we have a problem, we do bring the doc in so they can evaluate that new problem. From a billing perspective, if the doctor is assuming and taking over that visit, they've got to do all the components of evaluation and management themselves. So we're going to throw away all the time that the NP has already spent. The doctor will do a medically appropriate history, examination. The doctor will now do medical decision making. So from an operations perspective, that is not cost effective.
Yep.
To throw away that NP's time to try to capture that 15 minutes there, taking the doctor away from where he is, where he has to start over and do a whole new visit in order to bill for that. It's not cost effective. I can tell you right now, think about what that NP is getting paid salary per hour. And now you've taken a good 10, 15, 20-minute chunk away and thrown it in the garbage, because we got to start over again in order to bill this under the physician. So
Yep.
It's not cost effective, my friends, to say the doc's going to come in and deal with this new problem. It's all comes down to we're trying to capture that additional reimbursement, not throw money away.
Yeah. And then you've got patients that are under the physician waiting because now they've been pulled to come in to see this patient. So then you have that whole nightmare. And we all know what it is like sometimes waiting in physicians' offices to be seen. It's not always the smooth, you go with the time you're supposed to kind of thing, right?
Right. Because I'm going to leave. If I'm there and it's 30 minutes past my appointment time, you're losing my appointment.
Yep.
Because my appointment was here, I was here, you failed me. And then you're losing my whole evaluation and management. So you're not capturing a whole lot by that thought process there. Got to think of the bigger picture.
Yep. And love you, Pam. And
it just depends. It depends on the practice. It depends on the practice. It really does. And there's some specialties, like Betty and I work in dermatology a lot. Will you see incident 2 in dermatology? Maybe not that often. It might become more work than it is worth in a specialty practice like that, where most of the time someone's coming in with a new, rash, a gash, a boo-boo, whatever that is. And so it would take more work to try to determine those incident 2 visits. But if you have a primary care practice, a geriatric practice, then this could end up being beneficial if you have stable conditions that you're treating.
Yeah, because a lot of the derm conditions change from visit to visit. I mean, you think of it, a patient with acne, maybe they are laid down, but they come in now and they're flaring, or they're getting it somewhere else too. So they up their dosage, they down the dosage, or psoriasis, and now they're having a flare. And, so in dermatology, it's kind of hard to keep track, like we were talking about, where yes, they may have a treatment plan that's laid down, but it changes a lot depending on what the patient walks in with that day. And, you got a whole lot of skin, so chances are it's not exactly the same as when you
skin is the
started
largest
out.
organ of the body.
It is. Which you don't, by the way, have a right and a left of. I always get,
I know we do.
We don't have RTs and LTs in the skin procedures.
There's
You just
no
have
laterality in skin.
So, and then
I do have a better side. I mean, in case anybody
well,
wanted to know,
yes, you see this or this,
but
yes.
But that's right.
And then Julie, I just want to put up, because we're at our time already. Can you believe it? We had so many great questions. But Julie asked, is it being recorded? She'd love to share it with coworkers. So yes, Julie, actually all of these get recorded. And since you attended, you'll get a thing that'll show it was previously live, where you can go watch the recording. Or CHCS does have a YouTube channel. So I will send this over to my super duper graphics and computer lady, and she, makes it all pretty in the front and back. And then it'll be up on the YouTube channel probably next week. So you can go to the CHCS YouTube channel, and then you can watch all the previous. Christine, do you know I've been doing these for over 2 years now? Can you believe that?
Wow. Congratulations.
I went and looked the other day and I was like, oh, wow. And then I looked at me, I was like, oh, wow.
We're in season 5 of our podcast. And I say the same thing, like, season 5? Where did that come from?
So now, Christine, if you are looking for Miss Christine, don't forget you can. She has her Coding with Christine Hall podcast. This is Christine on LinkedIn. So if you want to go check her out on LinkedIn, Sterling Global Solutions is her company. So here's where you can find her company. And I forgot to put to pull over your podcast thingy, but
It's
her
okay. We're on almost all of the streaming platforms, Betty. And if you just go into YouTube, you can type in either Sterling Global Solutions or Coding with Christine Hall. It will take you to the right place. Can't
and
go
you will
wrong with
see
either one of those.
little Toby Hall.
Yes, my little Toby Hall, who has done such a good job of being a good
Yes.
boy
Hi,
today and hanging
Toby.
out. Yes, I love you too. Thank you. He's such a
And
ham.
then
Oh my gosh.
Sonal Patel and I have started a new um, uh, a new venture.
Venture.
We call it Compliance Capers. So it will be on Fridays at 11 Eastern, 10 Central. And we are doing this month was all DOJ releases. So we were looking at different releases from the Department of Justice.
Like your Friday fraudsters?
It's like my Friday fraudsters, yes, but we're moving on to something else. Next month, we're going to move on to advisory opinions and things like that. So, but I'm thinking about doing my Friday fraudsters as a one so I can go through them. I think that might be a good one too. So tomorrow, if anybody's interested, our compliance capers is on medically unnecessary services. So here is the link where you can find that. And I'll go and cut and paste all of these in the feed later so that everybody can, if you're interested, you can go click on it and find it. Find Christine, find the capers.
Well, Betty, I want to remind the listeners that if you have a question about Incident 2 and we didn't get to it, or you have a scenario, you can always reach out to us and email us. And we'll be happy to forward you that information. We've got a lot of resources between the two of us. Maybe you want to throw that CMS one up one more time so people can remember that we've got a great resource on it besides the two of us, and even most of the people that were on chatting with us today. They've also got some great insight on Incident 2.
Yes. So thanks y'all for joining us today with such a good session. This was so much fun. I always love having you on, Christine, and I always like when you can make time in your schedule for me. So I really appreciate that.
It's my pleasure, for sure.
And my next one, I am going to have one of my colleagues that I've known for decades, who is with the Oklahoma. She's out in Oklahoma with the Oklahoma chapter out there, and she's an anesthesia biller and coder and biller. And anesthesia was the one thing, how you always have one thing in all of that you're like, anesthesia is it for me. And it's not the codes, it's all the graphs and the pie charts and it would give me a headache, I swear. So she's going to be on and we're going to go through, how to do the anesthesia with the P modifiers and all that other fun stuff. So that will be a really good one too, if y'all are interested in how anesthesia
concurrency charts
works out. Yeah. So thank you, everybody, again. I hope y'all all have a good weekend and stay warm for those of y'all in the north that are really up under it. I feel for you, but I'm kind of cold at 67, so I know I'm a wuss, but
you're in good company, my friend.
Put on all your warm snugglies, and we'll see you next time. Thanks, Christine.